Welcome to the deep dive. I'm so glad you're joining us today. Because, if you look around, getting a hyaluronic acid dermal filler, it's seemingly as common as a haircut these days.
Yeah, it really is everywhere.
Right, people just pop in on their lunch break. But
Yeah.
today we are looking at the rare medical mysteries, the things that happen when it doesn't go as planned.
Exactly. And while HA fillers are generally incredibly safe, highly biocompatible, the human immune system and, well, the microscopic world of bacteria, they are highly unpredictable.
Yeah, they really are. So for our mission today, we're pulling from a huge stack of sources. We've got the Journal of Clinical and Aesthetic Dermatology, Frontiers in Microbiology, plus some really intense clinical case studies.
Oh, the case studies are wild.
They really are. And our goal here is to figure out exactly how a clinician plays detective. Like when a patient comes in with swelling after an injection, how does a doctor know if it's just harmless, benign swelling or if it's this hidden time bomb, like a late-onset submucosal HA granuloma or, a bacterial biofilm? Okay, let's unpack this. We have to start with the baseline, right? What does normal, albeit annoying, swelling actually look like?
So you have to understand the material itself. Hyaluronic acid is hydrophilic.
Meaning it loves water.
Exactly. It loves water, which is great for skin turgor and hydration. That's why you use it. But because it binds so tightly to water, it can cause excessive water absorption.
So it's basically like dropping a highly absorbent dry sponge into a shallow puddle. It's just going to hold onto that water stubbornly.
That's a perfect analogy, yeah. And this persistent edema, it usually starts within days of the injection. And it can hang around, persist for more than 4 weeks.
Oh, wow, a whole month of swelling.
Yeah. But here is what the clinician is looking for, the clinical signs. It is strictly non-inflammatory.
Okay, meaning what exactly?
Meaning there is no erythema, no redness, there is no pain, and there is no heat when you touch it. It has this very soft, pale appearance. Sometimes it even looks like little fluid sacs under the skin.
Got it. And does this happen anywhere on the face or?
Well, there are common locations. You see it a lot in the infraorbital area. So that's malar edema spreading over the cheekbone. Or you might get significant upper eyelid puffiness.
Because the skin there is so thin, right?
Exactly. The skin is thin, so that waterlogging is super obvious.
Right. So if that is the harmless, sort of squishy waterlogging, what happens when a lump is not soft, pale, and painless?
That is when you enter the territory of delayed onset nodules, or DONS. This term was coined by the ACE group.
Okay.
And the key here is the timeline. These appear after 4 weeks. The median onset is around 4 months, but it can take years.
Years?
Oh, absolutely.
Hmm.
And unlike that harmless edema, DONS are inflammatory.
So they are angry.
Very angry. They are firm, well-circumscribed submucosal nodules. They are red, they are warm to the touch, and they are tender. And this is interesting. They can actually wax and wane.
What do you mean by wax and wane?
Well, they fluctuate with the patient's immune system. So if the patient is under a lot of stress or maybe during their menstrual cycle, the lump will suddenly swell up and get angry again.
That is wild. And speaking of wild, I have to bring up this shocking case study from the sources. This was out of Saudi Arabia. There was a 34-year-old woman who developed a painless 2 by 2 centimeter granulomatous swelling a full 10 years after her HA injection.
10 years. Just incredible latency.
A decade later. But wait a second. HA is a natural sugar found in our own bodies. The filler is sterile when it goes in. Why is the immune system suddenly freaking out and attacking it months or a decade later?
What's fascinating here is that the etiology, the cause, is actually multifactorial. It's a mix of a foreign body reaction and these really stealthy bacterial invaders.
Okay, so it's not just the body randomly changing its mind about the filler.
No, not exactly. Let's break down the two main culprits. You have granulomas and you have biofilms.
Let's start with granulomas. What's actually happening under the skin there?
So a granuloma is a histological diagnosis. Basically, it's your immune system walling off a foreign invader that it can't destroy. If you look under a microscope, you see macrophages.
Those are the cells that usually eat debris, right?
Right. But the filler is too big. So they merge together to form multinucleated giant cells. And they literally build a fibrous envelope, a physical wall, around the filler.
Wow. Okay, so that's the body trying to quarantine the area.
Exactly. But then we have biofilms. And this is the plot twist. A biofilm is basically a bacterial fortress.
A fortress.
Yeah. The bacteria secrete this extracellular polymeric substance, or EPS. It entirely encases them. And it makes them 100 to 1,000 times more resistant to antibiotics.
1,000 times? That's terrifying.
It is. And inside this EPS wall, they enter a dormant planktonic state. They just go to sleep. And they only awaken when the conditions are perfectly right.
So it's literally like a medieval castle. Like the filler implant is the hill they build the castle on, the EPS is the thick stone wall, and the antibiotics we take are just like arrows bouncing harmlessly off the outside while the bacteria are just sleeping safely inside.
That is a highly accurate way to look at it, yes. And here is the real aha discovery from the research. Normally, for an infection to take hold in healthy tissue, you need about 100,000 microbes per gram of tissue.
Okay, 100,000.
But if there's a filler implant present, that threshold drops from 100,000 to just 100 microbes.
Wait, really? Just 100 individual bacteria?
Just 100. The implant is like a magnet for them.
That makes the risk factors make so much more sense. The sources mention things like applying makeup within 8 hours of an injection or having active acne. You're just pushing those few bacteria right onto the implant.
Exactly. Any tiny break in the skin barrier can introduce those 100 microbes.
But it gets weirder. There was this one wildly fascinating case study where the infection didn't even come from the skin. It was an improper endodontic treatment, a bad root canal on tooth 16.
Yes, the 216 case.
The biofilm literally traveled from the tooth root through the facial tissues and colonized the cheek filler.
It perfectly illustrates how connected the facial anatomy is. And it brings us to a huge problem for the clinician. Distinguishing between a completely sterile immune granuloma and a low-grade biofilm infection is incredibly difficult.
Because they look the same from the outside?
Yes, and worse, a biofilm actually triggers the granulomatous inflammation. The immune system senses the bacteria in the fortress, gets frustrated that it can't breach the walls, and so it builds a granuloma around the whole thing to contain it.
Oh man, so you have a fortress wrapped in a quarantine wall.
Exactly.
So how on earth does a clinician play detective here? I mean, you can't just swab it, right?
No, standard swabs almost always come back negative. The bacteria are dormant and hiding in that matrix. They won't grow in a regular lab culture.
So what's in the detective toolkit?
First, ultrasound. High-frequency ultrasound is crucial. It lets the doctor see if they are dealing with a fluid cyst, which is benign, or a hypoechoic solid granuloma, or even an active abscess.
Okay, so you can see the dense mass. But
Right.
how do you prove it's a bacterial biofilm and not just a sterile immune reaction?
That requires advanced molecular tests, things like PCR or Feisch fluorescent in situ hybridization.
FICH, right?
Yeah. These tests don't wait for the bacteria to grow. They look for stealthy biofilm DNA hidden in the tissue samples. It's molecular-level detection.
Okay, so let's say the clinician solves the mystery. They confirm it's an inflammatory delayed onset nodule, probably biofilm-driven. How do you treat a fortress wrapped in a quarantine wall?
You have to follow a very strict treatment ladder. Step 1, you start with broad-spectrum antibiotics, usually macrolides or tetracyclines. And not just for a few days, we're talking weeks, to try and penetrate that biofilm.
Right, because they are 1,000 times more resistant.
Exactly. Then step 2, you use hyaluronidase.
That's the enzyme that dissolves the HA filler, right? The nidus.
Yes, it dissolves the filler itself. But there is a crucial caveat here. You must have antibiotic cover established first.
Wait, why? What happens if you just dissolve the filler right away?
If you dissolve the HA scaffold without antibiotics in the patient's system, you instantly release all those trapped, angry bacteria into the surrounding tissue. You could spread the infection and cause a massive complication.
Oh, wow. You'd basically be blowing up the castle and letting the invading army run wild in the countryside.
Precisely. You have to have the antibiotic arrows already flying, so to speak, before you drop the walls.
That is intense. Okay, so you have antibiotics on board, you dissolve the filler. What if there's still a lump?
That leads to step 3. If fibrotic granulomas remain that thick quarantine wall we talked about, you have to calm the immune system down.
Because it's still overreacting.
Right. So you use intralesional steroids like triamcinolone or a medication called 5-fluorouracil. These shut down the immune macrophages and the fibroblasts that are producing all that scar tissue.
Okay. And if all else fails?
Step 4. Surgical excision as a last resort. Just cutting the whole mass out, which is what they finally had to do in that 10-year Saudi Arabian case.
Wow. So what does this all mean, like for the person listening right now who might just be thinking about getting their lips done?
If we connect this to the bigger picture, it means we have to respect the procedure. Aseptic technique is non-negotiable. You shouldn't be layering multiple different fillers in one area. And above all, it proves that aesthetic treatments are serious medical procedures, not just casual cosmetic touch-ups.
Yeah, absolutely. I think understanding this clinical detective work really protects you as the listener. Whether you are considering a cosmetic procedure, or maybe you already have fillers, or you just love understanding the microscopic battles happening in the human body, this kind of knowledge is really empowering.
It really is. It changes how you view the whole industry.
It does. And I want to leave you with one final kind of wild thought from the deep dive. The sources noted that researchers are currently studying the specific nature of biofilms created on HA. And it sparks this crazy idea: what if the dermal fillers of the future aren't just sterile?
Right.
What if they are engineered at a molecular level with peptides that actually actively disrupt biofilm communication?
Oh, to stop the quorum sensing.
Exactly. Could tomorrow's cosmetic injectables actually be designed to talk back to bacteria to prevent these sleeper cells from ever building their castles in the first place?
That would be revolutionary.
It really would. It's definitely something to ponder. Thank you so much for joining us on this deep dive into the sources, and as always, stay curious.